We have an amazing guest today. Shall we introduce her, and then
Yes.
we can give our information? She's Dr. Kelly Victory.
Yes, it's not Jay Moore, as the title says, Tom Cigar. Thank you. Kelly Victory is not Jay Moore.
I'll go back and change it later.
Dr. Victory is obviously a physician, and she is a frequent guest on various radio programs, as well as other places out in social media. And Susan keeps hearing her and kept coming home going, "You've got to talk to Kelly Victory. You've got to talk to her. You guys would really love talking to each other. She's so great." And lo and behold, here we are. Kelly, welcome.
Thanks for the invitation. I appreciate it.
So I almost don't know where to begin. I guess the easy place to start is what in the world has happened to our profession. It is what got me into trouble yelling about back in February. I could see the sea change a-brewing. I could see the hysteria coming. I could see this giant wave coming our way. And I tried to push back on it and help people navigate their emotions by pointing out that we had an H1N1 in 2009, which infected 500 million people, killed 600,000. We've only got 16 million coronavirus cases in the world, not 500 million like H1N1. So not that I'm saying coronavirus isn't serious and shouldn't be taken very seriously and it isn't something for us to pay attention to. I'm saying the panic is disproportionate. Do I have any point there, Kelly?
You're spot on, Drew, and that's been my point all along. I have never claimed that COVID-19 isn't real, that the virus isn't real, that it doesn't have the potential to profoundly impact certain people. The great news is we know who that group of people is, and so we can address it. The panic and the response has been unprecedented. Although I'm a trauma and emergency physician by training, I made the transition 2 decades ago into disaster preparedness and response and public health. And in my career in public health, I have never seen this sort of thing happen. This has become highly politicized. It's been the most divisive thing I've ever seen in my career in medicine. And you are exactly right. There's an emotionality about the response and an emotionality about the conversation that supersedes anything that we might even vaguely refer to as science.
Right. So now we have, to me, one of the bottoms we hit was where the New York Times board of editorials demanded a lockdown, as though they were public health officials or they should be dictating medical policy. And the thing I've been saying from the beginning is anyone talking to physicians about this? Doctors that are used to making risk-reward analysis, risk-reward decision-making, that if we do non-pharmacological interventions like a quarantine of the public, which, by the way, has never been done before, we will talk about that. But if we do something like that, it will have terrible consequences somewhere else. And now we're in the middle of that.
Right. And what I try to explain to people all the time is that let's look at the mandate of public health, Drew, is always to look at the broad reaching ramifications of any particular response measure. It's very different than when you or I might be sitting in an exam room one-on-one with a patient.
Right.
Our mandate at that point is very, very different.
Yes.
So when I hear people say, whether it's public health officials, and I cringe, or people in the mainstream media say things like, yes, but if we can just save one life. And I think, no, that is not the mandate of public health. We are making public health policy that is impacting huge numbers of people. Tens of millions of people are being impacted by some of these mitigation schemes, such as social distancing and mask wearing and locking down schools and all of these other things that we can talk about. But be very clear, public health has to look at the impact of any of these strategies on the entire population, not just on one individual, which is not to say that you or I or any other caring physician doesn't feel badly, that we don't mourn the loss of people who become ill and die.
It goes without saying. To me, the two fallacies are, well, how many deaths then? How many are we supposed to tolerate?
Right.
I don't know. How many we tolerate from heart disease, lung cancer, pancreatic cancer? You don't think that way with diseases. Diseases determine how many deaths. We struggle with trying to diminish the number of deaths. How many is acceptable? Of course, we'd love there to be none, of course. But we can't determine a priori what the number of deaths are that we're going to be struggling with. It's the disease that determines that.
Well, even with, if you look at, say I said, I don't ever want there to be another death from motor vehicle crashes. This is insane. We have too many. So the quickest way to do that is eliminate motor vehicles.
Well,
okay.
how about with the going back to schools, which is a 12-year-old died in Wisconsin. Too much. One death. Well, from now on, then 12-year-olds cannot swim. You have to get rid of swimming pools altogether.
Right.
Bicycles, forget bicycles. In fact, no sports. All that must stop if one 12-year-old death is too many. I guess we're going to have to keep the 12-year-olds at home forever. And even in the home, there's a little too much risk. I don't know. We're going to have to make – it's just such insanity we're doing now. Such insanity. And by the way,
right.
Before I let you answer, Dr. Victory, those of you on the thread, on the chat, you're chastising me. I see that. I'm too engaged with Dr. Victor right now to watch you guys. I apologize. I will get back to the chat. I promise I will get you guys. Susan, if you could note down any questions that come along that should be addressed, I will happily get back to them. But we're too busy right now with Dr. Victor.
Yeah, we'll get to your questions.
So go ahead.
We're watching.
One is too many.
No, so I think that fundamentally is where part of the problem is, that they've conflated a death with a failure. And unfortunately, when we are in the middle of an epidemic or any other disease process or any other, problem that happens as a result of trauma, as you said, drownings or car accidents or any, bicycle accidents, we have to balance as people in public health. How much can we do to mitigate risks? What is reasonable within the societal norms, within, taking into account people's civil liberties, that people have a right to make choices to do things that might be dangerous, whether it's riding a bicycle or driving in a car or swimming in a swimming pool. So instead we say, okay, well, we'll enact seatbelt laws and speed limits, and we'll put airbags in cars, so we enact certain public health measures. But then at some point, there is an element of risk, and we are not here to remove all of that. So here we find ourselves in a pandemic, and people have sort of lost sight of that, and they keep focusing on individual deaths, individual illness, and unfortunately, we can't do that. We need to mitigate risk as best we can within the realm of what's tolerable.
And understand that if we take excessive interventions, we will cause suicides, substance deaths, poverty. I mean, all these other things, a delay in the treatment of things like heart disease and cancer that will accelerate the death rate in other areas. That's a diathesis that you and I are used to looking at. Governors are not. They just are not. And they've been, they keep saying they're following the science. They aren't. They really are not.
No, in fact, what you're just referencing is what I call COVID lateral damage. It's all of the deaths and suffering and loss that people are suffering as a result of our response rather than the virus itself. And it's a very real entity. We've seen huge uptick in substance abuse, as you well know. Malnutrition, child abuse, depression, suicides, and delay in care. And a lot of the uptick recently in hospitalizations and ICU admissions hasn't actually been COVID-related admissions. There are people who got sick weeks ago and delayed care, didn't come in for treatment for diabetes, heart disease, cancer, whatever it was, and they're showing up in the ER, and we're saying, why didn't you come in 2 weeks ago when you started having chest pain? And they said, because I was scared. 100%. I didn't want to get exposed.
100%.
COVID lateral damage, and it's a real thing. The CEOs of both the Mayo Clinic and Cleveland Clinic wrote an op-ed back on June 9th saying that in their estimation, deaths from things other than COVID as a result of the lockdown were going to far exceed deaths from COVID itself.
We are seeing that already. That is absolutely true.